Hello, and welcome everyone to another exciting episode of Let's Talk Social Innovation in Health. It's a pleasure to have you join us today as we dive into a critical conversation about bridging healthcare gaps through innovation. My name is Andrew Hamuza. I am from the Social Innovation in Health Initiative Hub here at the Kamuzu University of Health Sciences, and I'll be your host. Just for the sake for those who have missed our previous sessions, this series is a spotlight for groundbreaking ideas and collaborative solutions that are transforming healthcare to be shared with the anticipation of learning, collaboration, and exchange of ideas. So today we will be exploring how VillageReach, in partnership with Malawi's Ministry of Health, is leveraging people-centered digital innovations to reach the last mile, strengthening supply chains, expanding rural access, and equipping health workers with data-driven tools. These efforts are not just about technology, but it's about putting communities at the heart of sustainable change. So joining us today, we have Stephen Simkonda, the informatics specialist at VillageReach, and Stephen will unpack how these solutions are driving Malawi closer to universal health coverage. And the important thing is, all these solutions are actually rooted in local needs and powerful partnerships. So whether you're a healthcare professional, whether you're an innovator, just an individual who's interested in innovation and health, we are so happy to have you in this space to engage, learn, and collaborate. Shortly, Stephen will take the floor and take us through this discussion. Thank you so much. Stephen, are you ready?
Yes, I am.
All right, thank you. You may take the floor.
All right, so I'll share my screen. Yeah, so as introduced, I'm Stephen Simkonda, and I lead implementation of digital health solutions at VillageReach, Malawi. And I'll be presenting under the topic of reaching the last mile with people-centered digital innovation for universal health coverage in Malawi. And let's begin with who we are as VillageReach. Please confirm if you're able to see my screen in presenter mode.
Oh, not yet, not yet. Kindly share your screen.
All right, thank you. Are we there now?
Yes, you may wish to take us back to the first slide. If this is your first slide, that's okay. Thank you.
Yeah, so this was the first slide, and that's our topic for today. Yeah, so let's begin with who VillageReach is. So VillageReach transforms healthcare delivery to reach everyone. We are driven by a vision of a world where each person has the healthy care needed to thrive. And we do this by working with government, the private sector, partners, and communities to build responsive primary healthy care systems that deliver healthy products and services to the most underreached. So if you see the map, we are working under three categories of countries. So we have what we call core countries. These are countries that we have offices in. So these are such as Malawi, Mozambique, Nigeria, DRC, and we have just opened a regional office in Kenya, Nairobi. We also work in other countries as partner countries where we work through other partners. So our innovations are delivered through other partners. And we have what we call technical assistant countries where we just provide technical assistance. Our mission, as indicated earlier on, is a world where everyone has the healthy care needed to thrive. And our mission is to transform healthcare delivery to reach everyone. So our impact as in 2023, we are currently working on finalizing the 2024 report. We helped increase access to quality healthcare for over 111 million people across Africa. And we supported over 675,000 health workers' ability to deliver products and quality health services to the most underreached. We also assisted in delivering for health products to and from 14,000 health facilities. So when we talk of responsive primary health care, we mean three things. A health care that is available when it is needed, even in the hardest to reach communities. So we are also looking at health care that adapts to changes in demand and better absorbs the shocks and stresses. And lastly, we are looking at healthcare that is responsive to the needs and preferences of underreached communities. So that's what VillageReach is. So in our work, we work in addressing challenges in the following areas: limited healthcare and access in rural areas, high demand for health services, especially during outbreaks and natural disasters. And we are also supporting in supply chain inefficiencies that are affecting essential availability of essential medicine and products. We also help with resolving workforce shortages and capacity gaps. All right, so we also recognize challenges in healthcare that are addressed by digital solutions. We also know that digital health implementations can address numerous challenges in the healthcare while also creating the new opportunities for improvement. For instance, resolving accessibility challenges where digital health initiatives can improve access to healthcare products and services, especially in the remote or underserved areas. And through telehealth and remote monitoring, as well as mobile health apps, accessibility can be improved significantly using digital solutions. We are also looking at the cutting costs in healthcare, whereby streaming processes, reducing paperwork, and optimizing workflows. Digital health technologies can help in cutting down costs of governments, healthcare providers, as well as patients. We are also recognizing that digital solutions can help in data management. So digital solutions can facilitate efficient storage, management, analysis, and security of patient and health supply chain data. And this can lead to better insights for personalized treatment and research. We are also looking at patient engagement and empowerment, where patients, systems like patient portals, wearables, health apps can enable individuals to actively participate in managing their health, leading to increased engagement and empowerment. And lastly, privacy and security, where digital health implementations focus on ensuring robust measures to protect and give security to patient data from breaches as well as unauthorized access. Now, how do we, as VillageReach, use these skills? So we have mainly three technical skills in which we help in resolving such challenges and leveraging technology. The first one is in technology architecture and strategy, where we have skills in enterprise architecture, interoperability of health systems, global standards, landscaping, evaluating systems, as well as piloting tech solutions to meet identified needs. We are also into software development and design, where we use human-centered design, user interfaces, software development, agile approaches to software development. We use also testing capabilities, migrations of systems, and also we use full life cycle development techniques. We are also into information systems implementation. So using all these skills that I've just mentioned, we use those to design and plan, train, and test, as well as deploy these systems in country, but also in other countries. So we are also specialized in project management, partnerships to build and implement capacity building, maintaining the systems, as well as the operations that are associated with those projects. Okay, so now let's look at examples of the systems or solutions that we have implemented in digital solution area. This is not limited to everything that VillageReach does. This is just a subset of what VillageReach does, because we are also into immunization, innovations, supply chain. We are also into workforce development. But for today, I'll just talk about the digital solutions aspect. Most of you might have heard about the Chipatala Chapa phone, known as CCPF, which is translated in English as Health Center by Phone. So this solution was developed in partnership with the government and private sector, such as Airtel and other donors that you will see at the end of the paragraph. And this solution aims at sustainability digital solutions that enables or engages both community and health workers through voice, mobile, and SMS or text technologies to improve health outcomes for all. So the solutions addresses the needs of clients, the caregivers, and even the health workers seeking personalized health information and support about their health, and addresses the demand in a number of ways, including, as mentioned, the hotline itself, remote learning, where we are able to disseminate information to the health workers even during pandemic. So we are also using SMS services in also disseminating this information. We are also into global health community of practice, where VillageReach is supporting the establishment of telehealth community of practice in different countries, including Malawi. So this is a forum that unites government, healthcare providers, policymakers, as well as researchers and academics, technology experts, as well as the community advocacy group to leverage the potential of collective action aiming to connect national telehealth communities and facilitate the knowledge exchange and transfer, continuous learning, policy, and solution development and implementation of telehealth solutions. So you can also see the partners that we're working with down there. We also help the government implement what we call a product catalog management for managing or cataloging the health products. So PCMT is an easy-to-use product catalog management tool that helps organizations realize the value of high-quality products, data to facilitate interoperability in the supply chain. So the solution provides deployment, configuration, customization, and technical support for use when you are when you are integrating solutions in the area of supply chain. Under the same area, VillageReach is a pioneer in electronic logistic management information system. So we are well known as implementers of Open LMIS. So this is a system that the government is using to manage health products. So we talk of drugs and supplies. So this is the system that enables the government and health workers to have critical information on the products management. You talk of stock management, you talk of knowing stock levels, expiration of products, and the like. So VillageReach is helping governments implement such a system. Going forward, since 2022, we have also been engaged in the helping government in the implementation of the lab sample transport solutions. So this solution enhances laboratory sample transportation using digital solutions. Not just these digital solutions, there's also another transportation component where we are engaging or working with the private sector in enhancing the transportation of samples from the district to the national level, as well as international level, where you have samples being referred to other international labs like in South Africa. So VillageReach is working with the government in integrating both the transportation as well as the technology, the digital solutions in enhancing sample transportation. So we are working in over 15 countries, including Malawi, where we're improving the timeliness and quality of samples, such as the AFP, the acute flaccid paralysis, the environmental surveillance samples, both of those are under polio, as well as mpox, measles tracking. So we use the what we call IoT, Internet of Things, to track these samples in real time, monitoring them, and we are also using the cloud-based data analytics in giving insights to the government on the details about transportation of these samples, so that we can use this data to optimize routes, as well as make sure that the samples are transported in the condition required. So these trackers are able to track the position of samples. They're able to track other parameters like temperature in which the samples are transported, humidity, weather shocks, and the like. So that's what we do, and those are our partners. We are also partnering with the PATH, HISP, and other donors like BMGF in implementing what we call equipment management system. So the aim of equipment management information system is to enhance the registration, tracking, maintenance of medical equipment across health facilities, ensuring real-time visibility of equipment availability, condition, and location by integrating it with the existing national systems like DHIS and the interoperability layer. So those are the partners that we are working with at the bottom. All right, so now what's our approach in implementing these systems? So I'll talk about our people-centeredness approach in implementing these systems. So we strive very much to make sure that these systems are implemented for the people. By the people, it means they serve the people's needs. All right, so how do we do that? All right, if you see this diagram on my right-hand side, we first learn and discover the problems that people are facing in the community together with the government as well as the partners. When we identify the problem through the process known as human-centered design, we make sure that we engage those that use these solutions. So that's the health workers and communities in designing and testing of the tools and services to ensure that these solutions are practical, user-friendly, and respond to the lived needs of the communities. So that's the learning stage. Now, after we have co-developed the solutions with the communities as well as the health workers, then we move a step further to develop now the ideas that have been formulated at this HCD stage. Now we develop them into the solutions, still together with the communities. And when we're developing these solutions, we make sure that we engage or involve the communities or the users all through. We develop these solutions and then we pilot them and evaluate them to say, are these really solving the problems at the user level? So if we discover that these solutions are not working, then we learn from that process. We don't force solutions that are not working for the government, that are not working for the community. If the solutions are not working, we do abandon them and learn from them and then move on. But once the government and the community agrees that these solutions are impactful and serving their needs, then we scale them. So piloting them, it might be maybe just a few districts or one district of a few facility, depending on the type of the solution. So if these are agreed to be impactful, then they are scaled up, whether it's national level, whether at scale, and then they are transitioned. So we have a very special program known as Transitioning Well, where we make sure that the solutions that are developed, if they are found to be impactful, they are taken over by a system that would sustain them. So in this case, it might be the government or it might be another partner. So the transition process is a gradual process that makes sure that everything that is required to maintain or to make the solution scalable are taken into account. So at this stage, as I said, if the solution is viable, then we can also replicate this solution to other areas or other geographies. A good example would be the health hotline, the Chipata phone, which has now been scaled into almost 3 countries or 4 countries. So it's now available in Mozambique. We are helping the Tanzanian government also scale up their health hotline. We're also helping the Kenyan government also nationalize their health hotline. And then the last stage is sustained. So we understand to say just implementing the solution and transitioning is not enough, but making sure that the whoever has taken up the solution, if it has been transitioned, sustains that solution. So we help sustain the solutions as well. So that's our approach. Then we also have what we call community insight to action approach, CITA. So CITA uses community feedback to inform and improve health services, translating local insights into concrete, measurable actions that drive accountability and system responsiveness. So what this framework does is to make sure that when we're developing these solutions, we have infused approach where these solutions have embedded community feedback mechanism so that the community are able to give feedback through the systems, and then that feedback is taken into account by whether the government or decision makers, and it doesn't end there. The decision makers should make sure that the feedback is given back to the community where it's coming from, and then using that loop, we are able to close the loop into community feedback and actioning those feedback. So that's what CITA does. So we're doing it very deliberately that all the solutions that we're implementing going forward, they have this feedback mechanism. I'll give you an example. The Chipata for the Health Hotline has this capability for communities to be able to, one, give feedback on the actual services that the hotline is providing, whether it's the hotline agents that are responding to the clients, whether it's the messaging that is being provided, all that. Callers can be able to give feedback on this area, and that feedback is analyzed by the hotline supervisor, and action is taken, whether a particular agent needs some monitoring as well as some coaching that is given to that hotline worker. Whether it's the messaging we need to improve, that messaging is also taken into account and then improved. Two, they are also able to give feedback about their health center service provision. If they go to a clinic, they can give a feedback about how they were treated at outpatient department, whether in the patient department, any department, whether it's at pharmacy, they can give a feedback to say, I went to the hospital, this is how I was treated, whether they were not given drugs, whether we have scenarios or data that shows some reports of maybe suspicion of drugs being stolen, availability of maybe inavailability of maybe contraceptive at the hospital, at the clinic for the youth, and so all this feedback is now consolidated by the ministry and then given to the district health ombuds person who acts on this data. So that's an example of how we use the CETA framework. I also give an example of the transitioning well project that was successfully transitioned to the government, which is the CCPF hotline, which went through all these stages, and now it's on a sustaining stage where the ministry is sustaining the project or the program. All right, so how does the future look like? So we are continuing advancement and adoption of digital health technologies that have the potential to revolutionize healthcare delivery, making it more accessible, efficient, and patient-centered. And we are doing that in these 5 areas: telehealth and facial care, where we're looking at helping the government implement telehealth services that allow virtual consultations, enabling patients to access healthcare professionals remotely, reducing travel time and enhancing convenience. We're also looking at healthcare data analytics and AI, so leveraging these cutting-edge new technologies like artificial intelligence and predictive analytics on healthcare data for personalized medicine, treatment, optimization, and predicting health trends, or even predicting outbreaks. We are also looking at health education and behavior change, which is being provided by the, for example, the health hotline. So we are enhancing this service by maybe developing mobile platforms and digital tools to educate, engage, and motivate patients towards healthier behaviors, empowering them to manage their own well-being. We are also in supply chain, improving inventory management by leveraging the new tools that I've mentioned to enhance inventory tracking and management across the entire supply chain by providing real-time visibility into inventory levels, expiration dates, and location, preventing stockouts and wastage. So these systems help a lot in balancing the stock levels, where you are able to easily know which facility has more Panadol and which facility is lacking Panadol, and then you can transfer products from one facility to the other, predicting when you are going to get stock out and the like. So that's what we are aiming to continue improving. Emergency response and management, expanding usage of digital tools during health crisis or natural disasters to enable quick and efficient mobilization of emergency supplies, aiding in rapid response and distribution where they are most needed. So one of the features of the health hotline that we help the government implement is emergency response, where they are able to respond. They have a special line that handles emergencies, and they are able to respond to those emergencies. So this has been so helpful during emergencies like outbreaks and cyclone Freddy's, where the minister is able to easily respond to these by communicating with the affected areas easily and be able to know the situation there. And lastly, doing all this, we are doing in order to have measurable impact in improving health information provision, increasing availability of health products, strengthening data visibility for decision-making, as well as empowering health workers and health systems. Yeah, that was my last slide. Thank you very much. I'll be welcoming questions and comments, and over to you, Andrew. Thank you.
Very, very enlightening. Thank you so much, Stephen, for such a wonderful presentation. I think we've come to that junction where we welcome questions and comments from the audience. So I'll leave it open. If you do have a question, do raise your hand and mic, and please pose the question for Stephen to answer.
Hi, good afternoon. I don't know how to raise a hand here. Sorry. I wanted to say congratulations to Stephen for this great presentation of the work that his team has been doing for so many years, and we are happy to recognize in even in our early brochures of CHI that one of those innovations, which was the health center by phone, which became very popular and received broad attention in Malawi. And we're very proud of the work that you have been doing. By the way, this is Michael from TDR. And I wanted to ask you, because you have so much experience in a range of countries in your region and beyond. Are there any specifics that have to be taken from your experience that have to be taken into consideration when we are talking to youth and engaging with youth groups and younger populations for the utilization of such tools as compared to my generation, which was a bit less technological and maybe more prone to rely on face-to-face and on physical contact and so on? Are there any specifics that would be important, like to define some good practices for engaging with younger populations, for engaging them in designing such tools and mechanisms and interventions? Thank you very much.
Hello, Stephen. I think you can attend to the first question, and then there is another one in the comment section. But I think you can begin with Michael's question.
All right, thank you. So yeah, Michael has raised a very important question. So VillageReach has experience in implementing youth based solutions. We once implemented a dreams led project where we are engaging adolescents in some districts of Malawi. One lesson that we learned is that the youth are more conversant, or I should say, they trust more technologies in expressing their needs. So I'll give you an example. When you look at the data in CCPF platform, you'd find that the highest calling group is the youth. And if you analyze the data, you also discover that when you compare their choice on speaking to a human being and accessing the content on their own, which is one of the sections of the CCPF. So you have a choice where you want to talk to a human agent, but you also have an option where you want to just listen to recorded messages. So there are adolescent messages or the youth messages in the platform, And when you look at the data, you find that more are preferring their listening to the recorded messages as opposed to talking to an actual person. So this just tells you that they value their privacy. So they are less comfortable maybe talking to someone, maybe issues of trust, whether they trust that person, and also they are comfortable accessing the content on their own because they know that they would listen to the content without someone knowing that they listen to that particular content. So that is one thing that we learned. So what does that mean? It means those lessons now are informing our future programming on how we deal with the youth when it comes to engaging them on their whether it's sexual behavior, broadly productive behavior. So let me stop there. Let me move to a second question.
Yeah, so the second,
Okay.
hello, the second question is in the comments section. And
Yeah.
can you see it? It's from Chikondi
Yes,
Miranzi.
Shikondi. Yeah, so I'll just read it. Thank you for the nice presentation. I see the focus is on tech, but how do you come in for other healthy innovations? Yeah, so as I mentioned earlier, I want to say this is not just what I've presented is specifically digital health, but there are other innovations that we are also doing. For instance, we have what we known as what we call immunization projects. One of them we use HCD, human-centered design, in designing immunization solutions for the last mile. For instance, we have a project that we're carrying out in Zomba, sort of a research project where we are looking at barriers to uptake of, for example, COVID-19 vaccines. So we were going to the community and then using the HCD approach to understand what are the misconceptions that are there in the community that are preventing the uptake of COVID-19. Later, we have also been doing that the same for another vaccination for girls. Just forgotten the name. Yeah, but we are using this approach and then we are understanding very interesting information that is coming out from the community. And then we're saying, okay, how do we address these misconceptions that are coming from the community together with the community? We are asking them, what is their solution? Because we cannot get that information and then come back and then design the solutions that we feel can resolve those problems. But we're saying, let's sit down together and then identify solutions that can work for this community. And then we come up with the solutions. Okay, I'll give you an example. The result of that, one of them is we came up what we call talking books. So talking books is a small device, sort of like a radio, that you can input in messaging, audio messaging, and then use those devices in a community, whether, for example, during vaccination days where women are waiting to vaccinate their children, and then you play such kind of a device, and then they get a message, they pass it to another mother, and then that message is relayed to the mothers. So you can see that we identified the problem, the community gave feedback, and then also gave feedback on the solution that they are looking for, and then we came up with a solution that was able to address the problems. I hope I have answered your question. So that's just one of 5 examples.
Simkonda, I hope Stephen has addressed the question. If not, kindly follow up with another question. The next one was supposed to be Obioma. I saw a hand, but I think she's temporarily dropped out. There is another question in the comments section from Victor, and he asked, for innovators interested in digital health innovations, does VillageReach support these independent innovators?
Yeah, so it's an interesting question. We have thought this before, maybe coming up with the innovation hubs. But you can see that your question is also similar to what I've just explained, to say if there is someone who has an innovation that thinks that can resolve a particular problem in a community, we are very much happy to partner with them and then explore how we can find funding to implement that solution. A good example is we're talking of for the Chipata phone. So if you go to the background of it, the way it started, there was a call for innovations, and there were people that were responding to that call, and one of the response is what brought Chipata phone idea. So it was an independent person that responded to call for innovation, and that innovation want to be something that can help the last mile, can help the community to have health information that they need anytime they need it without traveling from their home to the facility, which has brought huge impact when it comes to saving the community's time in moving from their home to the health facility, which sometimes quite very far. Some people travel over 20, 30, 40 kilometers to a health facility only to be told that no, you are stressed or you just need to drink a lot of water, and then they come back. That is time wasted and money wasted, because that time that they have spent, they would have been using that time to do other economical problems. So yes, I think we are open to ideas.
Thank you, Stephen. I think we do have Obioma now on the line. If you can hear me, Obioma, kindly unmute and pose your question. I think that will be our last question for the session today. Obioma, can you hear us? I think she's struggling with connection.
Yeah, so Andrew, I think there's another question from Andrew from Chikondi in the chat. Maybe if Chikondi can just verbalize that. I'm not fully understanding it, whether it's a question or a comment.
Oh, thank you, Chikondi. I think that's for your comment. I think the suggestion it's a suggestion to incorporate indigenous knowledge in the development of health tech for smooth adaptation. Thank you. I think that's a comment for you, Stephen.
Yeah, and I believe, I think it's alluding to the involvement of the communities in designing these solutions. Thank you.
All right. I think Obiama is still there.
Sorry. My question is, the phones or the health, telehealth, is it available to everybody in the community? Because, so that they can access messages and you retract them back. Is that the assumption that everybody in that last mile community has that telehealth phone? And
Yeah,
if
so
it's available, when you started earlier, how many people had it earlier before the increase?
all right, thank you very much. It's also an interesting question. So so this health center by phone solution is designed for the last mile. By this, what I mean is it enables the communities, even those that do not have, for example, internet access, to be able to call toll free. So they don't pay anything. So even if they don't have airtime, as long as they have even the simplest phone that can make a call, they are able to use that phone to call the hotline and then access these recorded messages. So to make it even more last mile suitable, when we were starting, we had two options where you speak to an agent, but we're also pushing messages, enrolling mothers to receive messages about the pregnancy as well as their child health. So we're able to push messages depending on the stage of their pregnancy and the age of their child. But what we noted was some of these messages were not being delivered, maybe because of network. Some of these messages were being delivered, but a survey showed that some of the recipients were unable to read the messages because they were illiterate. Then what we did was, remember where we are saying evaluation, we are able to evaluate this response, and then we are able to define the technologies so that we included the recorded messages, which do not need reading. So you just press 1 or 2 on the phone to choose menus and messages that you want to listen to. In that way, everyone can just listen. And these messages are in multiple languages, not just the national language, it's also in the other 3 languages in Malawi. So that was addressing the illiterate aspect of it. However, as you know, in Africa, most of the countries, phone penetration is still very low. Malawi is not an except. So that remains a gap. However, we also noted from the data that the people in the community are able to share phones to call the hotline. So there's instances where a village was able to use one phone for anyone in the village to call the hotline and then access these health messages. We also had a scenario when we started whereby there was an elder person in the community that offered himself to be a CCPF champion who could move around with his phone, and then people were able to use his phone to call the hotline. So such initiatives also helped in increasing access to the hotline. On the second question, on the number of people that were able to access initially when the hotline started, actually, it started with, I think, 2 districts in Malawi as a pilot, and then it expanded to about 9 more. And when the government noted that this was very impactful and they wanted to take it up as a national hotline, then we helped them expand nationwide. On the numbers, initial numbers that started, I don't have the figures on top of my head, but if you are more interested, then we can share those later on. Thank you.
Thank you so much, Stephen. I think it's been
Andrew, sorry, if maybe there's one critical comment or question in the chat that I would be very happy to answer if you have a minute or two for me.
Okay.
Okay, so if that's okay, Chikondi is further asking about young people complaining about long waiting times before the calls are picked and answered. It's a good initiative. How does M&E only usability work? Thank you. Yeah, so so that has been a big problem with the hotline. Call answer rate is still very low. So this is what enables us to start looking at other options to enable that will lower this call answer rate. And that's where we are now bringing in the option of recorded messages. So we have recorded messages almost on every topic. So when you go to recorded messages, you don't need even to wait on a queue to be answered. So you just go straight to the messages. So it doesn't matter how many people are calling at any given time, they'll still be able to access the messages. So that is one of the ideas. The second one, as I have alluded to on my presentation, is that we are looking at other ways using the cutting edge new technologies that are coming in to improve, to give multiple options to the callers to be able to access similar information that they can access when they want to talk to a human being. For example, we are trying to explore use of AI that is able to answer questions dynamically. Any question that a person asks, it should be able to answer within context of the question. So that's another way of looking at it. We're also looking at incorporating the symptoms checker. Actually, we had one implemented during COVID where callers are able to input their symptoms, and then the system was able to let them on whether they are susceptible to COVID-19 or they were safe, and then give advice and what they should do next if they're in danger of COVID-19. So those are the options that we are looking at in improving the answer rate. Thank you.